Hi, this is Adam Carolla. I want to thank you for supporting this podcast on the Carolla Digital Network. Everyone here at Carolla Digital is very proud of the shows that we put out every week and are excited about the future of our network. However, a patent troll is threatening that future by suing us. We need to fight back and beat the troll down. If we go down, all the other shows on the other networks you've grown to love are going to go down next. Visit fundanything.com/patent troll to donate and find out other ways that you can help beat the patent trolls. Thank you and mahalo.
This episode of Dr. Drew is brought to you by Hulu Plus. Watch your favorite shows anytime, anywhere with Hulu Plus, on your TV or on the go with smartphone or tablet. Shows like Family Guy, Once Upon a Time, New Girl, Scandal, and more. Right now, you can try Hulu Plus free for 2 weeks when you go to huluplus.com/Drew or click on the banner on my website. That is huluplus.com/Drew.
This is Carolla Digital.
And welcome to Dr. Drew Podcast. Very interesting show I've got planned for you guys today. This is in response to something that happened on Loveline on the radio program where I was talking to a gentleman, a man, whose girlfriend had a somatoform disorder, and I described how unrelated to any of the diagnoses that she had been granted, that she had to look into the fact that she might have trauma. Lo and behold, she did. She was a severe sexual abuse survivor, and I said, why don't you look into that trauma? Well, somehow that became this huge, huge problem because I mentioned that when people don't have a pathological diagnosis, in other words, you can't prove a diagnosis, they get multiple diagnoses, and we tend to call those garbage bag diagnoses. And somehow that became me calling endometriosis, which, by the way, was one of the many, many, many diagnoses this guy mentioned. I was somehow calling endometriosis a garbage bag diagnosis, which, of course, I was not. I've apologized on every platform I have, and I will apologize here as well, that if anyone felt diminished or harmed or not heard or whatever the feeling was that created, I've certainly apologized for that. I was not talking about endometriosis. I was not even talking to a woman. I was talking to an anxious man with a partner with somatoform disorder. And it's tough on the radio. You have like a minute and a half to make an assessment and then think of something to do that's useful for that caller and also sort of a teachable moment. But in any event, it raised the issue of endometriosis, which is a miserable condition. I've treated it for many, many years. Why people feel marginalized by it will be something that we'll sort of talk about here. Very kindly, Dr. Tamer Seckin, the founder, is that right, guys? The Co-founder of Endometriosis Foundation of America. He's actually calling us from Brazil. Dr. Seckin?
Yes, I'm online, Dr. Drew.
Hey, you're on the program. Thank you so much. I really appreciate you taking the time, and I know you're out of the country even. So I wanted to take a few minutes to talk about endometriosis since clearly there's a lot of emotional energy around this diagnosis for people that suffer, which understandably so. Did you hear what I said about how this all happened?
I just heard, yes.
Yeah. So there's been grotesque misunderstanding. And now, by the way, my family's in danger. People are calling me vile pig. This is the mob mentality of social media it's very, very dangerous. And by the way, multiple media outlets have picked up on it, misreported it, and substantively attempted to diminish my standing, which is, again, people trying to harm through the media and then can't be held accountable.
Not the media, I know.
Yeah, right, exactly. So anyway, let's get into the reality of this condition, how horrible and miserable it is. By the way, there's some websites if you want more information, endofound, endofound.org. Let's see if there's anything else. At the Twitter handle for @Dr. Seckin.
And drseckin.com.
Okay, Seckin is Dr. Seckin. And we'll have this all up on the website. So how did I get to you? How did you get involved in all this?
Well, it was Friday. I get out of the OR. I turn on my emails, messages. I said, oh, my God, what's going on here? So it was the Friday that everything broke, and I was so late to hear about it. It was in the evening, actually.
No, it was Thursday night that I took the phone call, and so by Friday it was a frickin' wildfire. So anyway, this am I reporting this wrong? Was this not a gross misunderstanding?
Well, I could understand the context of what you get into. I must appreciate, first of all, the opportunity to address this issue, and thank you for allowing me to express. I can't speak for all endometriosis patients, but this is a very, very strong community, and they have very negative feelings of being misunderstood. So we all are kind of being educated, me myself, all the time.
Because if the caller had called in and said, "Oh my God, my girlfriend has been given a diagnosis of endometriosis. She's had 3 laparoscopies. She has endometrial cyst now on her diaphragm. They're concerned that they may need to do a pelvic exenteration, and in the meantime, they're going to put her into menopause." I would have said, "Oh my God, endometriosis sucks." That's a story that I've seen a million times. And by the way, her fertility is threatened the whole time, whether she has the pelvic procedure or not. That wasn't the call I took. The call I took was a anxious young man whose girlfriend had a somatoform disorder and had multiple diagnoses, none of which were proven. Clearly, doctors were throwing the diagnoses into the garbage bag, trying to come up with some explanation for unexplained pelvic pain. Lo and behold, I came upon the sexual trauma. Now, I think the reason this maybe was a flashpoint is I'm going to speculate, and you correct me if I'm wrong on this, that a lot of people with endometriosis also have sexual trauma, and the endometriosis sometimes gets marginalized and not treated thoroughly because of that. Is that accurate?
Well, it's certainly true. Endometriosis is always dismissed. There's a huge delay in diagnosis, approximately 10 years. And I am not certain about the sexual trauma issue part of it, but there is always that possibility. But one thing is these patients are significantly symptomatic and really dismissed throughout their medical care.
Why?
And by the time they're diagnosed, it's really too late. The disease really is advanced. So they have really difficulty having sexual intercourse at times, because it's very painful. They don't have any life, really.
Why the delay? Back when I was more involved with gynecological procedures, there was a huge enthusiasm for laparoscopy. And back, maybe that's 15 years ago, there was a conversation about endometriosis being overdiagnosed. Is this now a backlash to that?
Well, there is. You might say there's a backlash, but there's also there is the prevalence of this. Approximately 1 out of 10 women gets hit with this.
Yeah.
And, in the world, there's approximately 200 women worldwide.
But of the 10% that have it, though, I think it may be more common than that, right? It's just let's define what it is. It's inspissated endometrial tissue outside of the uterus. It gets out of the uterus and gets all over the place. And during normal hormonal cycling, gets inflamed, causes pain, and it's really like having little periods all over your body. It's terrible.
You're right on that. It's a mini period all over the body, and it's because it does not involve primarily reproductive organs all the time. Majority is in the lining of bowel or other organs, so the symptoms are not specific initially. So if the right question is not asked, which is, are you having painful periods, or is it more than usual? Are you debilitated with it? So killer cramps is the main question everybody seems to miss, and they don't really ask. If it is so, they say, well, you get pregnant, it will be over. So that's the attitude many physicians also take. Along with families, awareness is poor, but the bottom line is once the question is asked properly, and there are quite a few questions around it, you can really extract endometriosis patient with the right questions, which is painful periods, gastrointestinal system, particularly around period time, bowel problems, as I said earlier, difficulty during sex, there's pain, pain, constipation, ovulation pain, leg pain, back pain, but it all has to be around the period. Then it becomes chronic. They suffer throughout the month.
Now again, back in the day, there was the huge enthusiasm for laparoscopic documentation. And we live in a different medical economic system now, where you can't do things you want to do to patients because there's no resources for it. Is that affecting all this?
You are right on that. I think the system, the whole, the practice of gynecology, the practice of medicine has changed. First of all, endometriosis is one of the main causes of infertility is endometriosis, actually.
Yes.
But
Yeah,
with
but
the
wait on.
IVF industry has really bypassed endometriosis. Nobody bothers in the IVF circles.
Okay, wait. Let's stop.
About their complaints.
Let's stop, because that, in my experience, that's the most although it's a painful condition, the most poignant, let's say, part of it is it has a dramatic impact on infertility and on fertility rather, and that warrants highlighting that if you have endometriosis, it's not a benign diagnosis if you intend to have kids. Yes?
That's correct.
Yeah. So
That's
how should it be? What's the workup then? So somebody has painful periods with these protein symptoms during the time of the period. What should the proper workup be?
Well, it depends patient's age and everything. Usually, one must understand the symptoms of endometriosis really 75% starts during the age of 12 when the periods really start. Mm-hmm. These kids should be picked up early in their lives, and they don't need to be laparoscoped, obviously, right away, but the algorithm, they need to be followed by a caring environment, medical, family-wise. Awareness is the key, and doctors have to really know about this disease. But the bottom line is the workup really comes up to a doctor who really knows about endometriosis. So usually it is a sonogram, it is an exam in the office. Many times with the exam and certain with the exam in the office, sonogram and by the story, by the complaints, the diagnosis is there, really. Very clearly it is there. But the final diagnosis has to be the standard by laparoscopy. Even that is not enough. It has to be under microscope.
Oh.
So that's the key to this.
Meaning microscope in the laparoscope, or meaning biopsies and then look under the microscope?
Well, the lesions need to one of the really sad part is we gynecologists have significant role on that. Many of the endometriosis patients, even though they're diagnosed, they are mistreated.
So let's talk about the treatment.
Undertreated, and there's lots of incomplete procedures are being done.
Yeah,
so that's another aspect of it.
Okay, there's that. And then to me, the treatment is part of the tragedy, because the treatment, the way it's applied anyway, is sometimes worse than the condition. So let's talk about treatment. What should proper treatment be once somebody identifies this condition?
Well, proper treatment obviously starts with education of the patient. So the fear factor should be abolished, and the trust has to be given by the physician that this is a treatable condition with the right approach. And the right approach is when it is seen, it needs to be removed very cleanly, very precisely. With all elements that margin-free removal has to be done.
Is that an open?
That's called excision surgery.
Is that an open?
When it is done, really, many patients do exceptionally better.
Is that an open procedure, or is that through laparoscope?
That's a laparoscopic procedure, but it is really intense, very difficult technically. However, it is with the people who does this all the time, it is very feasible. I'm
going to ask you a totally this is almost a sidebar here. The Da Vinci, I had a prostatectomy by the Da Vinci Robot. I'm super fan of the Da Vinci, and it's been used a lot more recently in gynecological procedures, not so successfully. Will the Da Vinci ever be deployed for this?
I'm sorry to tell, I may disappoint Da Vinci people, but I think the endometriosis is the last area that Da Vinci has to get in, because many of the surgery, these lesions are like tip of the iceberg.
Yeah.
And you can't really do these surgery if you're not feeling it. In Da Vinci, you totally lose your touching feedback power.
Okay. Well, there you go.
It's a great instrument, but it's just an instrument. It cannot make an average surgeon a better surgeon, really.
Yeah, I totally get what you're saying. All right, so that to me, that actually is exciting to me, because I have a feeling that one of the reasons people became less enthusiastic about making how can doctors not be aware about endometriosis? If somebody comes in with dyspareunia, which is painful intercourse, the first thing you go is, well, it's an infection. Is it an ovarian cyst? Is it endometriosis? That's it, right? I mean, that's the work. That's the initial thought the doctor has. So how they could not be aware of endometriosis is almost – there's got to be an explanation for that. So then I think, okay, well, now – back in the day, over the years, the treatment of endometriosis has been draconian. So I wonder if people sort of shy away from the diagnosis because they don't understand the effective treatments that are now available. They immediately jump to, oh, Christ, we're going to put this woman into menopause. I don't want to do that.
Well, many doctors are not trained to do endometriosis surgery. They don't get it enough in the residency program, and after that they get into a very heavy cycle of workload of delivering babies, seeing patients, pap smear, breast cancer screening, this and that. Endometriosis doesn't take any priority in their life. You can't do endometriosis surgery by delivering a baby till 5 o'clock in the morning, then 8 o'clock surgery. There's no way you can do it. And even the surgery is very challenging. It takes many years to get expertise on it.
So what do we do with that? That to me is the most exciting thing you're telling me, is that there's this curative procedure there. You don't have to shut down the pituitary and put them into menopause, which is, by the way, again, that's horrible when they end up doing that to women. It ruins their lives emotionally as well as sexually.
It's terrible.
Yeah.
At a young age, they go and look and they diagnose and give Lupron.
Yes.
As you were just going to say.
I think that's
why it's worse, and you're basically punishing the girl who
I agree with
already gets the worst diagnosis in the world, and you're putting her to menopause.
Yeah, I think that's why they avoid the diagnosis, because they don't understand that's what I would think. I would think, I don't want to give her that diagnosis because then we're going to go down this path, and I don't want to go there. Do you think that's happening?
That's happening all over, and this is, I must say, I have, this disease is really unforgiving. We see patients with sciatica pain,
of course,
lesions there. Yeah. We see patients with nephrostomy. These are patients whose kidneys do shut down. Their bowels are obstructed. Yeah. And obviously, the nature of my practice, I see the worst cases that are with 10 surgery, 6 surgery, and none of them had excision surgery. None of them had their endometriosis removed. Many of them don't even have a pathological diagnosis. So there is a big burden on practicing physicians, particularly on us, gynecologists. If we don't really get ourselves together on endometriosis, I don't think it's fair to the public to have anything change, because the teaching in the programs of residency and medical schools have not been there. However, lately there is some awakening. I must say that also.
Does being on the birth control pill help this?
It does.
Okay.
Definitely it does.
It's
not treatment, though. It just masks it, but it's not treatment. Any pain symptom that breaks birth control pill suppression should be evaluated. And people who are established with the diagnosis of endometriosis, who are on birth control pill, needs to be checked frequently, because some form of endometriosis still do progress, and it's a progressive disease, and birth control pills can mask the symptoms and progression of the disease.
Does pregnancy reduce the progression rate?
Well, pregnancy does not cure or treat it, but obviously with pregnancy, the symptoms are delayed another month. After the periods resume, the pain comes.
Oh, so it's...
I just want to get you back on this cure business. I think we should be very careful with endometriosis and cure, because I like to use it's highly treatable.
Okay.
The cure is, there's always microscopic disease. There's always very, very unhappy patients around. It is very unfair to them, really, if we say there is cure,
Well, but
in certain cases, if there's a congenital malformation, you take care of it, then you can say for those group of patients, yes, there's cure. It doesn't come back again.
Right. You're right. Again, this is how I get myself in trouble, by not speaking with... It's impossible when you're just talking to somebody on a radio or podcast. You just have to qualify everything. But yes, by curative, I mean moving towards cure, as opposed to in the past just suppressing. And you're actually removing the inciting agents. And yes, you have to chase them because there are lots of them. So let's go back to the multiple procedures. So back in the day, you diagnose it a laparoscopy, and then you'd fulgur and they'd burn it. Right?
Unfortunately.
Right.
It makes it worse. When you burn, imagine a burn on the skin. It contracts the skin, it makes it ugly, and it heals very bad.
So are they training? Are they training the gynecologists to do something different now?
Well, we are pushing for it. That's why I am at World Endometriosis Conference in Brazil. You should see there's really thousands of people here. It's so lively, and young physicians are so enthusiastic learning. I don't see really this much interest in the United States on endometriosis teaching, unfortunately, but it will happen. And really, it's the patient that really is changing also the scene. There's significant social media movement on it, and patients they're so aware. They know better than doctors, many doctors right now.
They need to be careful. They become dangerous bullies at a certain point, and that's not a way to create allies. It's not. They need to
I
be.
think many of them are so, but I will carefully agree with you or disagree with you. But the bottom line is, they are very understanding when you hit the right tone with it, because they need people who does understand this.
Of course, they need to build.
It has a political wrap up in one end, so it's a very important social disease.
But
it
it's
involves
not
the lady. It involves, in your case, the husband who doesn't know anything about periods.
Well,
they have no idea.
Right.
They learn it through their girlfriends, and they're so helpless.
Yes.
And it's their parents, it's their children gets affected.
Yeah.
It's very terrible, and it's really treatment. I have to say. And you would not disagree with me, the surgery itself, if it's not properly done, for the people, even for us, it is much difficult than cancer cases. Cancer cases are easy. Known cancer, you go on. Most of them are early diagnoses and they're clean. But when they come to us, it's all over.
No,
so it's
you're
very
chasing
difficult.
it.
It's
You're chasing it. Is there somewhere that people can peek into this conference on the internet? So if they want more information? Uh-oh. There you are. We lost you for a second.
I'm here. Are you asking the question to me?
Yeah. I was asking, is there some way to peek in on this conference? Is there something on the internet we can look to sort of...
I am not sure it is online, but it is World Endometriosis Conference in Sao Paulo. You can log in. I'm not sure it's being broadcasted live.
Okay. What else would you like people to know about this, other than raising awareness, change physician training, understand the range of treatments, be sure to be aware of asking the right questions, making sure people – I guess this internet, this podcast goes out to people, distributed throughout the country. Not everyone has access to high-level specialists. The average gynecologist, what should the average patient go in and say to him or her to make sure the proper workup and attention is being maintained?
Well, I think the most important thing is early diagnosis, and early diagnosis and proper and timely intervention is the best prevention of the disease, progressive disease, prevention of it. So, the idea is being aware that the disease cannot be treated with hormones and birth control pills completely. If the symptoms persist, there has to be proper intervention done, and this proper intervention has to be excisional surgery, not burning, not lasering, not Da Vinci, not those things that are very, I would say sexy terms in medicine to get patients, but they don't work. They need to really see specialists that does this, and for specialists who patients can trust. So there is a proper use of birth control, because I agree with them. Many patients should be on temporarily and see how they respond, but if they don't respond, they should get treated. A sonogram of small cysts, for example, that persists. Many doctors don't do anything about them, but endometriomas that starts in the ovary, for example, they become like chocolate cysts.
Yeah.
And many of them are misinterpreted, are normal cysts. The patient's pain continues, and these patients, it's from ovulation, nobody pays attention. Actually, that cyst is every month leaking and implanting all over.
You're talking about
ovarian
cysts that are
endometrium are the worst type because they tend to spill all over, from diaphragm all the way up. So no cyst should be sit by any doctor if they are persistent.
So every ovarian cyst, let's state it in a way that people can hear it. Every ovarian cyst that persists over what period of time? Years, months?
No. And more than three months. 3 months. That has a consistency of chocolate cyst should not be sit on, in my opinion.
So those should
regular literature, for example, says, hey, wait till it's 6 centimeters. If the patient is symptomatic, 6 centimeters or the size of it is irrelevant because it's leaking and emptying itself every month.
So have a laparoscopy at 3 months, right?
Unfortunately, that's the way to go, but it should be done safely by people who does it all the time.
It's I listen to what you're saying about seeing a properly trained specialist stuff, and I get crestfallen a little bit when I just think about how hard it is for people to get to the right care, regardless of what their diagnosis is. There are many different frustrating diagnoses out there that some people do a great job of taking care of, and general, out in the world, general sort of community practice can be frustrating. It can be very, and especially the way the system is going now, it's going to get worse. So
and
again,
one more thing I like to emphasize is family history of endometriosis, family history
very
of
important.
hysterectomies,
Yep.
family hysterectomy of troubled periods,
Yep.
which is in the old time never get diagnosed, particularly family history of ovarian cancer. And there's a group of endometriosis, and it's not very small on American ovarian cancer group. It's almost 15 to 20% of the ovarian cancers today we know are endometriosis driven. So with excision surgery with proper attention, one may think that and there's literature that supports that, we could decrease the ovarian cancer rate probably. And possibly these women should not go into menopause. Possibly, I'm saying. There's not enough research on this, but they should not be let go menopause with their ovaries having, all the pelvis having endometriosis. We really don't know. Majority of ovarian cancers really pop out at the age of menopause.
Yeah.
We really don't know how many of those women had bad reproductive years with cramps and other problems.
And again, just a side question, and would sustained treatment, hormonal contraceptive, reduce that risk of ovarian cancer, do we think?
Well, we know that's true. I mean, in reproductive for other reasons also. I mean,
maybe this
ovarian cancer is associated with, as you know, with multiple ovulations and things like that. It's been pointed many times.
But maybe this is part of that story too. It just hasn't been sort of connected.
Exactly.
Yeah. Well, listen. So I was saying about how frustrating it can be out in the community trying to get the proper care. I think this is a great opportunity to say, an educated patient, a patient who's motivated, who keeps going back, who doesn't take no for an answer, who really works with their physicians, doesn't make it adversarial, but doesn't stay away from the system if they're not getting adequate attention or don't feel like they've got an adequate, complete explanation for what's going on for them. The doctors want to do that. The system doesn't want you to do that, but the doctors want to do that. So please be educated and go back and go back and go back until you feel satisfied with the explanation. And, Dr. Seckin brought up a couple of times, pathological proof, actually being able to look at your condition under the microscope. This is how I got into trouble. That guy I was talking to, I guarantee you that girl never had a pathological diagnosis. That was why she had multiple diagnoses, because no one ever took the energy to really prove exactly what was going on with her. And again, she may have not had resources for it. It may have been impossible, but that's our system. So you keep going back. And if you think endometriosis is a likely explanation for the misery you may be in, it's important not just from the standpoint of now we've learned ovarian cancer, it progressing, fertility. Go to endofound.org, Endometriosis Foundation of America. Educate yourself. Dr. Seckin, are you present there on that website?
Yes, I'm the founder of the foundation.
But they'll see your words.
They will see my name as a founder. Yes.
Great.
Yeah.
All right, listen. Is there any last thing you'd like to say? I really appreciate you joining me and helping sort of educate about this stuff.
Well, first of all, I do like to thank you for giving me the opportunity to converse with you. I like everyone to know that killer cramps are not normal.
Yeah. And
our foundation has done significant progress on this matter. I like to really acknowledge my co-founder, Padma Lakshmi here also. She's been really
she down there with
powerful.
You?
I'm sorry?
Was she down there with you at the convention?
No, she's not.
I've done some stuff with her.
She's been exceptional voice in getting this to the attention of the media.
Yeah, and she's, I think everyone knows who Padma is. She's, Chris and Gary are like, we know who Padma is. Look her up if you have any questions, but it's important to have a spokesperson like that. And hopefully people feel in the endometriosis organizations that they now have a place they can refer people to hear you talk about these sorts, because this podcast has pretty good reach. It gets out.
Well, it's not only me. There are quite a few doctors who does what I do, and I'd like to emphasize this. We all know these problems, and we agree. We tend to agree with every aspect of what I said. They are unanimously agreed upon in my circle of friends who does this type of surgery.
Dr. Seckin, thank you so much. Back to your Sao Paulo convention. I really do appreciate you taking time to talk to us.
Thank you, Dr. Drew.
All right, take care now.
Bye.
Before I go to break, and we're going to take a break and then welcome Dr. Jennifer Parks in after the break. But before I do go to break, I want to mention our friends at Hulu Plus. Now, you've undoubtedly, everyone knows what Hulu is. Everyone has used that. But Hulu Plus is more, much more. You can watch current seasons of your favorite shows like Modern Family, Daily Show, Scandal, current ongoing seasons, and watch every episode of shows like Nashville, Lost, Doctor Who. You get ad-free movies and, there's kid shows. Now it's time to take control with Hulu Plus. Stream these shows, thousands more. You can it works on your on your smart TV, Roku, Apple TV, Xbox, PlayStation, pretty much anything streaming, you got it. Now, you can also now watch on your iPhone and iPad, which is ridiculous. You also get originals that you can't get anywhere else. Deadbeat, a comedy about pot-smoking guy who talks to ghosts. I have to see this. Sounds awesome. I will see it because my kids use Hulu Plus a lot, so then no doubt I'll be exposed to it, and I will use it. You also get and it's just $79.99 a month. Get shows anytime, anywhere. It's like $0.25 a day. So sign up at huluplus.com/Drew, J-W, to get 2 weeks full access completely free. Again, we give all this free stuff away. I don't know how these guys do it, but they do. Whole extra week more with this special offer when you sign up at huluplus.com/Drew. So get with it and start streaming TV with Hulu Plus now. Take a quick break and back with Dr. Jennifer Park.
Allison Rosen.
Hey everyone, it's me Allison from Allison Rosen is your new best friend. On Thursday, I sat down with Matt, Chris, Jenna, and Gary, and we tried to figure out who was the most, quote, fit with a kissable face. And then on Monday, Dave Damashek stopped by, again, to tell all about the tough issues.
I mourn the fact that I have no dancing ability. If I did, I would dance to and fro, here, there, and everywhere. I don't have it, though. Men, though, should not be using emoticon.
And to spread his good cheer.
It's all going away! Nothing matters! Lighten up!
Subscribe to Allison Rosen is your new best friend on iTunes or go to AllisonRosen.com. New episodes every Monday and Thursday. I love you.
Allison's your new best friend.
Buying a car can be a stressful experience. TrueCar.com is changing that forever. Simple, fair, and a fun way to buy a car. TrueCar users save time and money, helping them to never overpay.
You know you get the fair price because they show you what others paid for the car you're looking for. TrueCar analyzes what people are paying for their cars in your market and shares it with consumers so they never have to overpay.
Genius. Over 1 million cars have been sold by the TrueCar Certified Dealer Network, and users see an average savings of $3,046 off MSRP. Drew, stifle yourself. 3 steps here.
All right.
Go to TrueCar.com.
Yeah.
All right was not stifling yourself. Go to TrueCar.com. Find out what other people paid.
Then register to see upfront pricing information and lock in your savings certificate.
Then take it to the TrueCar Certified Dealer for a hassle-free buying experience.
Save time, save money, never overpay. TrueCar.com. That is a preview of Volume 3 of the Swingin' Sounds of Dr. Podcast. Gary likes this one. I can see it on his face. He thinks it's cool, right?
Yeah, absolutely.
Chris and Russell and I have gone to great lengths to select just those songs that you guys will love. So please support that at iTunes at dr.com.
You should have heard the pride in Chris's voice before we started, and he just mumbled, yeah, I'll give him a little preview.
Well, what I like is his face lit up. I've never seen him light up to anything. He doesn't like the other stuff we picked out, Chris. I'm sorry.
He's picky.
He is picky, but we're in there. We'll find something for everybody. And for your summer parties, get part 2, but part 3 is coming. And please be sure to support the people that support this podcast by getting Hulu Plus and Sherry's Berries and all the things I talk about today, and clicking through at the Amazon banner at doctor.com. We've been talking about endometriosis for reasons that have been beyond my control. And that was we just heard from Dr. Seckin, who is an international expert on this topic. I hope everyone learned something. But I want to bring it back down to earth a little bit and bring Dr. Jennifer Park in and talk about hormone replacement, another thing that makes women miserable and is unattended to. I think that to me, that's why it's sort of dovetailed into this topic for me. Let's back into it this way. Well, describe who you are in your practice.
Oh, well, I'm a OBGYN. I practice both obstetrics and gynecology, but I do have a special interest and love of menopause and hormone replacement.
Did you a fellowship in that or something?
No, just fell into it in a way. I worked for a doctor who was very involved with menopausal women, and just learned from her. And then I moved out to California and just kind of started.
Where was that?
In St. Louis, Missouri.
Okay. Mm-hmm. Was it part of Wash U or something?
No. Just a practice that was also again just had a
Very
special interest and involved.
Why did you see? I mean, you must have been early in your practice. How did you notice that was a significant problem?
Basically, I worked for this doctor who found this method of hormone replacement that worked very, very well for her patients. It was hormone pellet therapy. Yeah. And she was at.
Did she discover it, or was she? She
was a gynecologist who had a hysterectomy and
herself
was undergoing terrible menopausal symptoms and looked for the right answer. for herself and found pellets to be the answer. So even as a gynecologist, she had to go look for something that would work for her.
Well, I have noticed how profoundly altering menopause is for women. I've been practicing general medicine for almost 25 years. And when the Women's Health Initiative was evaluated, where we were all told that now the science is out and we must take women off hormone replacement, it was devastation for men, and I knew it would be.
Oh, absolutely.
It was like, this is ruining people's lives for maybe some reduced risk, but not even clear, because there was a good, big, long study, but it was on a very narrow population,
Absolutely.
right?
Yeah.
Yeah. And so I was noticing back when, early in my practice, I thought, wow, these women that are 90 all are on hormone replacement and they're quite alert and spry. I wonder if that means something. I mean, always.
Absolutely.
Always.
Yeah.
And then I'm looking at these 75-year-olds who feel like shit and have never been on therapy. I thought, I wonder if that has something to do with this. So I got interested early, and when we were all mandated, to take women off hormone replacement. I always explained it to every patient. I said, well, the science now suggests we need to take you off. My experience suggests, and many of my colleagues' clinical experience suggests there's something wrong with this study, but we're obliged to take you off, so let's try it. But know that if you and I want to together keep you on it, here are the potential risks, here are the potential benefits. Let's talk about that. What are the potential risks and benefits?
Yeah, well, actually, nowadays the North American Menopausal Society did come back.
I know. It's swung back. I knew it would because it just didn't make any sense.
Yeah, absolutely right. And they looked at the data a little more carefully and divided it by age group. But actually, in the women in their 50s, there was less heart disease seen in those women.
Who started replacement and stayed on it?
Stayed on it, and within, they said, 10 years of menopause, if they started hormone replacement, they actually saw less heart disease.
That fits,
in those women.
and I'm going to bet, you haven't proven this yet, less cerebrovascular disease.
Yes. Yeah.
Absolutely. Okay, go ahead.
It also, it showed a decreased risk of bone loss.
Osteoporosis. So, of course, we knew that. Everyone knew that. But again, the earlier the better, right? Because the rapid bone loss is right when you get into menopause. So you protect women against that. All right.
Absolutely. As far as dementia cognition, it actually didn't really show any difference. But
I think that may be a cerebrovascular thing, ultimately.
Yeah.
Okay. We were talking about blood vessels, arteries in the brain.
Yeah.
Okay. So it's good. And how about in terms of breast cancer risk, ovarian cancer risk, uterine cancer risk?
Ovarian cancer, there was really no difference. Hormone users and non-hormone users. As far as breast cancer, it was those that were on combined
with estrogen
and progesterone, again, both synthetic. On top of that did have an increased risk of breast cancer. There was an estrogen arm of the WHI, the Women's Health Initiative, of estrogen alone. And they studied that as far as 7 years and did not see any increased risk of breast cancer.
Which is kind of weird. It's the exact opposite of what you'd expect.
Exactly.
Because we think in terms of progesterone protecting estrogen receptors and from the stimulatory effects of exogenous hormone. Synthetic. You had a certain twist in your voice when you said that. Talk about that.
Yes, so synthetic hormones are different than what our body used to make.
And by the way, let's be fair. It wasn't synthetic. It was horse urine. Yeah, straight out of horse urine initially.
It was, yes, from a natural source, but not really a human source. I suppose if you want to say that. Synthetic hormones are different than human hormones. Basically, the Premarin is very, very similar to a very potent estrogen called estrone that our body makes.
Well, I'm going to get in the weeds here a little bit. I thought Premarin was 9 different estrogens.
It's a conjugated equine estrogen essentially.
And the Premarin comes from what's the name for a female horse? Mare. The mare.
Yes,
the mare is right in there. Pre-Marin.
Pregnant mares.
Pregnant mares is where they got the damn hormone from, everybody. But I thought it was estrone and estradiol in there, and then several others. No,
mostly estrone.
Okay.
It's mostly estrone, and. So it's not estradiol, and estradiol is kind of what we're shooting for now in most hormone replacement, and even in this day and age, patches and gels are available for women in the form of estradiol.
Synthetic estradiol.
It's still estradiol. Estradiol chemically down
estradiol
is what we want. Yeah.
So why did you, when you said synthetic, you sort of...
synthetic is, again, it's just
but you had a little disdain in your voice when you said synthetic.
That's what the study was on, something synthetic versus something that's...
Well, what I'm pushing for is whether your bioidentical is also synthetic or is bioidentical something different.
Bioidentical is estradiol, and that's what we're shooting for. Chemically down to the chemical, we want it to be basically estradiol is what our body wants, and needs and functions with.
Let's talk about the constitutional effects of. We're going to walk through each of the hormones because I think this is the important thing. We haven't even gotten to the important stuff, guys. So listen carefully. The important stuff is coming. I'm building to that. The constitutional effects of estrogen on women who might need estrogen.
You mean
constitutionally? How do they feel?
Oh, in general, I mean, it helps with mood.
So their mood is a little better with that. But some people get off mood on estrogen. Sometimes it can make them moody.
Too much,
yeah,
perhaps too much. But most women present with depressed mood when they don't have enough estrogen.
So, mood good.
Hot flashes.
Okay, those will reduce hot flashes. We said protect bones. Sleep better.
Disturbances.
Sleep better.
Dryness,
vaginal dryness, which is, by the way, I did a whole couple of podcasts on this with a guy named Goldstein, who was talking about the Gary, if you put up there which episodes that was, about the effect of powerful progesterones in the current oral contraceptives and the cause of vaginal dryness and dyspareunia and mood disturbance and stuff. And it's common, it's profound. So anyway, vaginal dryness is corrected.
Yeah.
Dr. Goldstein.
As well as just dry eyes, dry mouth, hair loss.
I'm gonna let me throw in something that people don't talk about very much. I think it's important. Episodes 7, 12, and 39 of Dr. Goldstein, where we talk about this and how to identify it and how to test for it and all this stuff and what to do with it. And there's a book out there, by the way, called Why Sex Hurts on our website. You can click through and get that I'm hoping also talks about endometriosis. I haven't read it, but Dr. Goldstein tries to go through every little possible cause of sexual pain. Estrogen also causes something called I call receptivity. That women are more receptive to their partners and sort of is that a term that makes sense to you?
Yes,
receptivity,
absolutely.
yeah.
Yes.
Men don't understand this concept. It's something I've observed in patients, and they've described it, and it's an important thing.
Yes.
Can you put words to that?
I do also think that's a function of another hormone too, which
testosterone.
Well,
I think testosterone. I think we're going to get to that, but I think. I bet testosterone amplifies receptivity, but receptivity is a uniquely female human sort of. Men don't have receptivity, because that's why they're confused by it. They're like, "Huh, what is that?" How do you explain that? A willingness to sort of be. I don't know if I have words for it as a male.
I mean, it's a good term, receptivity, being, I guess, willing and
openness, open to receiving somebody.
Exactly. Yeah, open to receiving something, namely even when you're talking about intercourse and sex and desire, being willing to act upon your desires.
And somebody else's desires, like being receptive. And men, you should be aware, men have zero experience with it, zero. They're testosterone driven. They're going out. Okay, so estrogen has significant benefits, limited risk, and you particularly would say the pellets are a good way to go. Why, as opposed to patches or pills or shots?
Mainly because it delivers the hormone into your bloodstream just like your ovaries used to. So it's the most physiologic. I mean,
meaning in terms of the low continued tonic release.
Yeah. I mean, when we were cycling, actually, we had highs and lows, but actually the pellets make you more stable, and women feel.
Why is that different than a patch?
Well, patches is probably the closest, I would say, to the pellet in terms of delivery system. I mean, it gives you a nice stable level. It'll drop off at the end of the week, and you just have to replace
your colleague that was looking for a solution that find the pellets? Did she go through the patches?
Yes, she tried everything.
And why did those not work as well for her? I wonder.
I think partly it was lack of testosterone. There was.
So let's get into testosterone. So really, the reason I asked Dr. Park to come in here is about the forgotten hormone for women, which is testosterone.
Yes.
I think I was trained that the majority of women's testosterone comes from their adrenal glands, and that after menopause they're fine because they're still making it from their adrenals. But in point of fact, the major producer of testosterone in a woman is their ovaries.
Yes.
And when their ovaries shut down, they lose testosterone. I actually was involved with some research on this 15 years ago at Cedars. They were doing some endocrine research on this. And I was talking to these women who were going from shut down to turned on, and we'll talk about what that is. And the endocrine community was like, no, we're not. I'm not sure anything really is happening. As women were describing what you've seen, I'm sure these
absolutely.
vivid changes, and it never really. You see, it still hasn't caught on really. What is that?
I don't know. I don't know if it's just a lack of just for women's health, a lack of priority for women's health and needs and. want.
Like women aren't supposed to be sexual or directed
Right.
after a certain age or something.
Right.
It's really comical. Now, we've always had Estrotest, which is a combination of estrogen and testosterone. And I've seen that prescribed a lot, but it doesn't seem to have the same effect.
No, it doesn't really get your testosterone level high enough.
And how do we decide what high enough is?
I do somewhat by blood levels and just by how they feel.
How they feel.
Yeah.
Is there any risk to replacing testosterone?
No, not that we know. Not in females. I mean, there's side effects, but there's no risk of cancer. In males, you have to watch their prostate, but for women...
well, there's now concern about vascular illness. And you see the recent study in men? Heart attacks and stuff.
Although that was very specific. I mean, that study was on a very specific population, much like the WHI. It was on older men who had heart disease.
Yes. Well, not only that, but I would imagine the opposing effects of estrogen would protect that.
Absolutely, yes, absolutely. They get a combined effect with the estrogen.
So what happens? So the side effects are hair growth, lowering of the voice. I imagine they might reverse some of the bone loss.
Absolutely. It's actually the only thing that builds bone.
Yeah, it's testosterone.
In women. But the side effects are manageable. You can lower the dose. You can adjust the dose. There's medications you can give.
So why get on it? What do you see?
I'm sorry,
why would one want to get on this? What do you see?
Oh, for mainly symptom relief more than anything. So low libido. It helps with energy, mood, fatigue. I'm
going to ask you to speculate wildly. A lot of postmenopausal women are on antidepressants.
Yes.
What percentage of those do you think could be treated successfully with testosterone and no longer need their antidepressants?
Oh, I mean, a good probably 90% of them. And
You're saying something rather bold.
Well,
I, who's an enthusiast, would say maybe 60-70%, because some of that's got to be depression.
Right, some is depression, but maybe they'll need less.
But the point is they don't think about the hormone replacement, and it's massively important for women. Massively.
Absolutely.
It's frustrating. I don't understand why it's not. Well, let me ask this. Is every woman respond equally well to these replacements, or is it sort of a mixed bag?
It's a mixed bag, I'll say again, because you're right. There are patients who have other issues, and we can't fix everything.
But even if it is, let's say it's a cohort, let's say you have 20 just purely postmenopausal symptom with pure menopausal symptomatology, and you're going to put them on those pellets. What percent are going to be not only completely relieved of those symptoms, but like feel better than they have in a long time?
You mean out of 20?
Out of 20.
Isolated.
Yeah. We're going to assume they have no other conditions.
Yeah, then I would say 90%. A good portion of women would.
See, that's crazy that we don't consider that routinely. How about perimenopause? Let's talk about that, because that's where this stuff really spins out of control. It's where marriages are ruined. That's where careers are changed. People make and perimenopause can be a long window, and it can start at a very young age.
Absolutely, yeah. And I do think that is the testosterone factor there. Testosterone starts to decline after we're 35, and symptomatically, really in the 40s, women start to feel that lack of testosterone, which is basically irritability, worsening PMS. Some get migraine headaches. Weight gain in different areas, loss of muscle. That's when those are all classic perimenopausal symptoms, and that happens in the 40s. So I treat those women with testosterone in that group. They're still making estrogen. We don't give them any estrogen. We let that run its course,
and they get better.
And they get better. PMDD, severe PMS works. Testosterone works very, very well for that.
Should we be giving it to very young women?
No. I mean, testosterone can cause birth defects, so they have to be done having kids.
And let's weave in a little bit endometriosis, which was sort of the opening topic on this podcast. Is any role to be played there? Any issue and interplay with the women that have endometriosis?
As far as I know, there's no contraindication to getting hormone replacement if they've had endometriosis.
Mm-hmm.
I'd be careful in them because we do believe it's estrogen driven.
Endometriosis.
Endometriosis.
Yeah.
So but for those that have had a hysterectomy because of endometriosis, which is a treatment for that, as far as we know, as long as as the surgery was successful and there was no visible endometriosis, a low dose of hormone replacement is reasonable.
I'm going to ask you an opinion. Is there excessive enthusiasm for hysterectomy for endometriosis? I'm kind of surprised how often they go to that. Or is it okay? It's adequate.
It's adequate. I don't feel like we excessively do hysterectomies for endometriosis.
Okay, because it looks that's a non-gynecologist. It looks like really, it's an awful lot of surgery. A lot of hysterectomies.
I don't feel, at least in my practice, I don't feel like we do a lot for endometriosis.
All right, so we have to wrap up in about 5 minutes. So let's sort of give people an understanding. Oh, okay, good. 10 more minutes. An understanding of how to access this kind of treatment and how to know if they might benefit from it. Who would you like to see, and where should they go? And by the way, please do promote your practice, because I've seen you do magic. So if they want someone, they're out here in Southern California, go see Jennifer Park.
Yeah, they could. Well, they have to talk to their gynecologist and really talk to them. I mean, tell them what your issues are.
Are they likely to get a sympathetic?
It depends on their attitude and how much they know about it. There are a variety of other hormone doctors there, but have
is there a
levels.
Website?
Well, we have ours, which is just www.fowh.com.
FOWH.
Fair Oaks Women's Health.com.
FOWH.com. And do you give information there in addition to?
Yeah, I mean, I actually have an email. They're welcome to email me and ask me any questions if they like.
Okay. And if I could say, I specifically asked Dr. Park to be here because I believe she's really on to something. And I've believed this for way before I met you. I thought this testosterone, because I was in that research at Cedar, and I thought this is remarkable, and it's being ignored. And then to see patients go through these transformations where they feel like a lot of them are pissed. Like, why didn't somebody come up with this 20 years ago? I could have skipped some Prozac and other things. And I understand that. It's, again, I don't know what's our problem, that women aren't supposed to be sexual or aren't supposed to have testosterone, or if they have libido, it's an out-of-control vagina. We're in trouble now.
Right. Yeah,
weird.
Absolutely. I don't know. And there's Viagra and there's all the other these other medications for men available.
But for men, we don't worry about it. Well, that is another point. I wanted to ask this myself, because what's the word I'm looking for? Selfishly. I'm jealous of people get on. Can 50-year-old men get on testosterone?
Oh, absolutely, yeah.
Do we know the risks?
I mean, there's lots of good studies out there that shows that there's benefit in men.
I don't have a prostate. Disease. You can put that stuff in me. Let's go do this. But I've had prostate cancer, so would that be a contraindication?
Yes, that's I mean, it can stimulate a prostate cancer.
But I'm PSA 0.
Yeah, I mean, you could do it. Yeah, I mean, just watching that very, very carefully.
Or would the urologist just freak out?
Again, it depends on their experience level with it. But yeah, no, I think you
can you give low-level testosterone to guys?
You
just
can.
A little bit?
You can. I just certainly I mean, the levels
I'm going to bust my urologist's balls on this. Because it really, men have the same thing.
Absolutely.
It falls off, and it really significantly affects their vitality and mood and all kinds of stuff. The question is, at what risk?
Right, and I think there does need to be a study on healthy 50-year-olds. So maybe healthy 50-year-olds
on testosterone. Are you implying that I am
pill.
not healthy? How dare you?
No, because the study that just came out was on unhealthy 65-year-olds.
Yes,
so I really would like to see one on healthy 50-year-olds.
But when you look at guys, you have anabolic and androgenic steroids, you see oncogenesis of all kinds, especially prostate cancer, and you see vascular disease, hypertension, kidney disease, whatnot. But so it makes you wonder, but we're talking about just replacing things back to normal, aren't we?
Exactly. And actually, there's been studies that show that if you replace men's testosterone back to the level it was, their lipids get better.
Oh, that's interesting.
Yeah. I mean, there's probably, just like in women, when the decline of estrogen, their lipids go off. There's got to be some...
I'm going to bet, though, there's some function of testosterone somehow on the mechanism of cholesterol deposition in the intima, above and beyond the actual circulating levels of cholesterol and fat. I'm going to bet. Maybe it's even blood pressure mediated or blood volume mediated or something, but I'm going to bet there's something there. But we should be able to control for that. We should be able to give enough that you don't cause those sort of – because I don't know, it just doesn't make sense to me that – again, this is part of the bias we have. We're biased against testosterone generally, it seems like. Right?
Right, yeah.
We don't want to give it to men. We don't want to give it to women.
Well, I mean, I think it's I don't know. It works well. It's a little bit more natural. It gets us off other drugs.
Other medication, yes.
That are, make a lot of money. I don't know if that
and also have a lot of side effects, like shutting libido down. That's a big side effect from SSRIs. And so relationships are profoundly affected by this. I mean, a woman is already without libido, and then you shut her down further with an antidepressant. For God's sakes. No wonder things are falling apart. You have a book. There's a book out there about this, right? The Forgotten Hormone or something?
Yeah. The Secret Female Hormone is written by the doctor I learned it from, Dr. Kathy Maupin, who's in...
We got to put that on the website, gentlemen. Got it? On it? On it. Secret Female Hormone, yes, and?
It's written by Dr. Kathy Maupin, who I learned this from.
Okay. So. Dr. Park, I got to wrap up. Is there other things you'd like to say, mention about your practice?
Oh, no. I mean,
Like
if they're
people
interested,
call you, email you. You could get deluged with emails. And by the way, if you're male partners of females with these kinds of issues, email Dr. Park. I mean, she may be able to sort of enroll them in this way of doing things.
Yeah.
I'm very enthusiastic about it, and I hope it catches on for other practices throughout the country. Are there localities doing it? I mean, do you guys have conferences of pellet replacement therapists?
We're hoping. I mean, Dr. Kathy Muppin is trying to train other doctors around the country. If there's an interest in learning, it's physicians too that are out there that want to learn about this. You can talk to me about it or Dr. Maupin.
You may get deluged with email. Be careful here. This could be a lot.
But they just need to.
I wanted to help you and to help patients, not put you underwater or spend your whole day doing emails. So,
but they should talk to their doctor, try to get maybe their levels checked. And look into it as a viable cause for their symptoms.
I bet you what's going to happen is a lot of people are going to get it put on patches and creams, which is probably okay, right?
Yeah, it's better than nothing. I mean, it's absolutely better than nothing.
And one last question. Why is a testosterone pellet better than a cream, like androgel?
For some reason, creams the absorption is variable. There's transfer issues with transferring.
To your partners and things.
Partners. Yeah. Some of my women have kids. I mean, young kids.
The kids get it.
So it's just issues.
So what we're saying is that you put these testosterone creams on your skin and then you rub against your 9-year-old child and all of a sudden his voice drops.
Yeah, exactly.
Yeah.
So you got to be cautious with creams. Some of there's a lot of hormones convert between other hormones, so it just tends to do that more.
Testosterone goes to estrogen.
Estrogen or dihydrotestosterone, which is a more potent form of testosterone.
Is that bad?
Yeah, I mean, it can cause hair loss.
Balding, okay.
Yeah.
And so this one doesn't do that?
Not as much. I've not in my
That's
experience
weird.
have I seen it. Maybe just because of the way it's delivered, it goes right into your bloodstream.
There's
just
got
like
that's got to be an explanation for that.
Yeah.
That's a peculiar one. Well, I want to be a guinea pig of yours as soon as I can convince my urologist.
Absolutely.
Well, it's clear I don't have metastatic disease. I don't know what that time is. If it's 3 years, 5 years, or what. What doctors, just for the listeners, what you do after a prostate cancer surgery is you look for tiny, tiny metastasis that it spreads elsewhere. It shouldn't have happened to me because they seem to have gotten it early enough, but you never know is the problem. And so there's a 2% chance of it coming back. The question is it worth that risk to feel good for a little while? I don't know.
Right.
All right, Dr. Park, thank you so much. Before we go to wrap the show up, I want to remind people, in addition to hormone replacement, you can make your female partners feel better with Sherry's Berries, everybody. How's that? Chris, had a good, Gary, good transition? All right, order a gift for even your mom or your girlfriend or your wife. Make it as unique as she is. Giant freshly dipped strawberries delivered from Sherry's Berries starting at $19.99. That is a 40% savings, more than 40%. And you can double the berries for just $10 more. Click the mic at the right upper corner and use the code Dr. Drew, D-R-D-R-E-W. White chocolate, milk chocolate. I can't resist these things. These swizzles and chocolate chips and the ones with the nuts, I can't resist. It's ridiculous. So visit Berries, BERRIES.com. Click the microphone at the top right corner. Type in Dr. Drew. That's Berries, BERRIES, Berries.com. Click the microphone. Type in D-R-D-R-E-W. The deal expires Friday night at midnight. So order now for Mother's Day. So, Dr. Park, let's give out all your vital stats here. Give me the website again.
Oh, it's www.FOWH, FairOaksWomen'sHealth.com.
And I don't really want to give out a phone number.
Yeah,
because
they can find everything else on there in my email.
I don't want you to tell you just stuff. I'd be kind to her. This is something that I'm enthusiastic about. Is there anything else I need to mention about your practice or website or how to make an appointment? No, I think I've also got your email. Do you want to give that out?
Oh, yeah, you can.
You sure?
It's on the website. It's free
Dr.
reign.
Park, D-R-P-A-R-K, at FOWH.com. If you have questions, I hope we don't overwhelm her. But this is really important stuff. It really is. I've been wanting to do this for a while, and I'm really appreciative that you came in and talked about it. And hopefully more people will avail themselves of this, particularly you ladies that are perimenopausal. You might be 30 years old and wondering why you're so irritable and unhappy. And it can be just perimenopause, the whole thing, and people don't think about it.
Yeah.
All right, that does it for the Dr. Drew podcast. We'll see you next time.
For calling times and topics, follow the show on Twitter at Dr. Drew Podcast. That's DRDREW Podcast. The music from today's episode can be found on the Swingin' Sounds of the Dr. Drew Podcast, now available on iTunes. And while you're there, don't forget to rate the show. The Dr. Drew Podcast is a Corolla Digital production and is produced by Chris Loxamana and Gary Smith. For more information, go to drdrew.com.
This episode of Dr. Drew is brought to you by Hulu Plus. Watch your favorite shows anytime, anywhere with Hulu Plus.
on your TV or on the go with smartphone or tablet. Shows like Family Guy, Once Upon a Time, New Girl, Scandal, and more. Right now, you can try Hulu Plus free for 2 weeks when you go to huluplus.com/Drew or click on the banner on my website. That is huluplus.com/Drew.
This is Corolla Digital.